Hi. Yeah, I've got a major trauma call. Yeah, 52-year-old male. Yeah, he's been bitten in half by a shark. Injuries at... No, I don't have a BM. You want him in the waiting area? Hello? Hi. Welcome to the January 2025 read-through of the Emergency Medicine Journal. I read it so you can pretend you have. My name is Kath. I'm a trainee advanced clinical practitioner in a couple of EDs in the north of England, paramedic by trade, and this month's issue is a pre-alert party. So, let's get into it. The meat of this month is talking about the pre-alert studies. There's a few other little bits we'll get into as well. So, there's 3 studies in this month's EMJ, all about ambulance pre-alerts to EDs. They are from the University of Sheffield in conjunction with Yorkshire Ambulance Service, and they are talking about when you call ahead to an ED, let them know that you're bringing a patient in because you think they're poorly, because you think they're going to get poorly, or because there's a pathway that they fit within. So let's talk about these 3 studies. So firstly, the first study is a survey of ambulance staff. Second study is a qualitative piece of semi-structured interviews with emergency department and ambulance staff. And then the third is an observation and semi-structured interview of ED staff. So we start off with the ambulance perspective, that's a national survey. Then it's talking about attitudes towards pre-alerting with emergency departments and ambulance staff. And then at the end, we're going to read, then for the third one, they went to EDs to see how they were doing and talk to a range of stuff as well. So not bad going to get 3 citations for one issue. So good job, everyone. Let's get into the first one. So this one is called Variation in Ambulance Pre-Alert Process and Practice, a cross-sectional study of ambulance clinicians. So this was a national online survey of ambulance staff. So there were nearly 1,300 responses. And the idea of this going first is just to kind of set the scene beyond Yorkshire. And their aim was to inform recommendations in practice. So they know they want to get into pre-alerts. Let's see what the situation is at the moment. So it's part of this larger mixed method study, part of these 3 pieces that have come out of it. The conclusion was guidance and training is needed, which is a bit of a no-brainer. So it's interesting to get into the specific issues raised in this. So there are issues with under pre-alerting, so not calling people through when you should be, and there's also issues with over pre-alerting, which is calling in people who don't need to be called through. The latter, so over pre-alerting, can result in pre-alert fatigue, where EDs don't really take you seriously, whether that's you or everyone. And there's local service variation. So it's worth mentioning here that there is some national guidance, which is the Association of Ambulance Chief Execs and Royal College of Emergency Medicine. They put out joint pre-alert guidance in 2020, but most trusts deviate from these. So there is, in theory, this guidance, but in reality, that's not really been adopted. And there's loads of local variants, which is a problem we see loads pre-hospitally. Things are different in every trust. And actually things can be different from a hospital perspective between hospitals. So if you are working as a paramedic and your patch includes multiple hospitals, you might end up with having to kind of carry around what you pre-alert to which hospital. And, you know, like this hospital might have a NOF pathway, whereas this one doesn't. So you need to ring through NOFs there, but not there. So it ends up being a little bit messy, and it's quite a lot for clinicians to carry in their heads as well. If they need to if the pre-alert criteria are different for each hospital, they end up having to make messy decisions. So in terms of the existing practice of pre-alerting, 65.8% of respondents said they'd had no specific training about pre-alerts at all. 59.2% had learned when to pre-alert from mentors or colleagues, which fits with my experience. I spent 2 years as a student paramedic working with a mixture of mentors, and you kind of would just see what they do. And I think the thing with pre-alerting is you've got those ones that are obvious pre-alerts, like every cardiac arrest you're going to pre-alert. And then you have some that are very protocol-y, like if I pre-alert this NOF, they're not necessarily time critical, but they want to get the X-ray booked and they want to get the, a radio, a bed that can go into X-ray and stuff ready. It's the ones in the middle that aren't as clear. So that's working out which patients will need extra attention, which patients are likely to deteriorate or are deteriorating. And I think the way I learned was vibes, just vibes. Kind of just, if it's making you feel like you need to do a pre-alert, then do a pre-alert. And it seems that's pretty common in that people aren't getting any kind of training on it. They're just kind of picking up like, what is the done thing for pre-alerting? And then 9% of respondents felt that ED clinicians always listen and take the call seriously. So this kind of cuts to the problem here, which is this is quite a common point of tension. Having worked pre-hospitally and in the ED, eye rolls after the pre-alert phone calls from both sides are pretty common. And everyone is a backseat pre-alerter in ED, I have to say. So that was the first study, which was the survey, so kind of getting a sense of like where ambulance staff are at. Then the second study is semi-structured interviews with ambulance and ED staff. So this is called What Influences Ambulance Clinician Decisions to Pre-Alert EDs, a qualitative exploration of pre-alert practice in UK ambulance services and EDs. Okay, so let me double check. I don't think this is the one where they actually went to the EDs. I think this was semi-structured interviews. So there's 34 ambulance staff and then 40 ED staff across 6 EDs. And the ED staff was a mixture of medical side and nursing side. So what have we got? Firstly, pre-alert decisions involve a rapid assessment of clinical risk. And I think that if you are someone that makes pre-alerts or receives pre-alerts, it's worth understanding like what is actually going on here. And clinician is working out recognising poorly patients, recognising potential for deterioration, and kind of thinking ahead of what their care is going to look like and what that presentation is going to look like. So there's quite a lot going on there, and I think sometimes it's useful to like reverse engineer the decisions that you're making in a way that feel intuitive, especially if you've been doing it a long time, but then actually breaking down what you're doing. So yeah, rapid assessment of clinical risk, put that on your CVs. And what did we find? They found that 42 to 56% of pre-alerted patients don't meet established criteria. So half pre-alerts are inappropriate. They name experience and confidence as key factors, which makes sense. I think something interesting is the way that like a lot of people's practices is influenced by your lost patient or like previous things when it's gone a little bit wrong. And it's interesting in ED because you see seniors behave, they will, if they've had like an adverse event or something go a little bit wrong, it can make them behave differently for a little while afterwards. And I think that's true for all clinicians. I remember bringing in someone that she kind of presented with something sounding like esophageal varices, but we couldn't see any evidence. All her obs were totally normal. There was no blood anywhere to see, so I didn't call her through because it's like, well, we've got a hemodynamically stable patient. She's just mentioning a possible episode of hematemesis that we don't have any evidence of. So we're like, we'll just get them to eyeball her when we get there. And then when we were waiting to hand over, she then started vomiting copious amounts of hematemesis, and then was kind of pulled into resus, and I felt really stupid for not pre-alerting. So, that's interesting because after that, if there's any hint that someone might have varices, then I would pre-alert and be ready to look a bit stupid. So a lot of confidence is one thing and experience is another. I think everyone has a kind of unique experience sometimes in terms of the jobs that make them twitchy. There's also some discussion around support for clinical decisions. Like there was frustration from the ED side that ambulance staff would ring to get a senior support in terms of making a decision, because they kind of felt like this was ambulance service putting work into the ED. And we have seen the development of clinical hubs where you can ring ambulance side for advice, but then there's some discussion of this, of paramedics being like, well, I'm only speaking to a paramedic, like why would I talk to someone that's like alongside me? I want a senior decision. And also some resistance to a perceived loss of autonomy, which I think is quite a big thing for paramedics. I guess if you have the option to ring for advice, fine, but I know that for newly qualified practitioners in my area, they have to ring for clinical hub when they want to leave patients at home and things, and there can be frustration around that of like, actually, like, why can't I make these decisions and why am I having this autonomy taken away from me? I feel like, okay, so this was this was the one where they also sent a researcher to EDs to observe pre-alerts being taken and also to see resource handovers. That's how they've got that half pre-alerted patients don't meet established criteria, because they're then observing them coming through. So I don't clarify that too well at the beginning. So yeah, those are some findings and points of discussion. Conclusion: there is potentially avoidable variation in decision making, and standardisation is needed. So roughly in line with what we saw first, is it's a little bit of a jumble, and things fall through the gaps, and half of pre-alerts don't need to be pre-alerted. So, third paper. Now we're going to the other side of the phone. The people picking up the phone rather than making the call. So this is called How Do Emergency Departments Respond to Ambulance Pre-Alert Calls? A Qualitative Exploration of the Management of Pre-Alerts in UK Emergency Departments. So this is observation. Let me pull it up again just to make sure I'm not totally lying. Yeah, so this is the same. So they did semi-structured interviews with ED staff across a range of jobs, and then observation in those EDs as well. So they've got three papers out of some overlapping research here. So they talked to 40 ED staff across 6 EDs. So what are their findings? So pre-alerts are resource intensive, which I guess sounds obvious from an ED perspective, but it's not always when you're making a phone call. And I guess sometimes it's chill if you're like, oh yeah, I'm bringing in enough, and then there's a bed free, and so then it's just like, yeah, there's enough going in there, just pull the curtain across. That's very little resources needed. But then if you think up to the other end of the spectrum and you're getting major trauma calls where they're bringing major trauma teams down from the hospital, or maybe preempting ordering blood, things like that, then, or moving people around in resus to get them out to get a bed free, then it's potentially really resource intensive and can slow things down. There was a perception that handover delays increase the number of pre-alerts, and I guess this is because of what we were talking about earlier when you're making those rapid assessments of clinical risk. If the variable changes of I guess it means you don't have that middle ground of like, I don't love how this patient looks, but their numbers are okay and like things are okay for now. I don't think they need like immediate full blown everything, but let's just get someone to eyeball them at handover, and like, you know, I'm happy that they'll like have another set of obs done pretty promptly, and then I'm going to hand over pretty quickly. Like if you're not getting that anymore because you're joining an hour plus long queue in ED to hand over, then you're going to make different decisions, and it's like, actually maybe I do need to kind of make a bit more noise to get this patient looked at. So then that creates this feedback loop where the busier it is, the more likely people are to pre-alert, which is then drawing resources away from everything else, because it's a very resource intensive way of seeing a patient. Which then makes it busier, which then causes more pre-alert. So we can end up in this feedback loop, which is partly due to these like systemic pressures that we're all working within. Interestingly, from an ED clinician specific perspective, they felt that in general under alerting is riskier than over alerting. So they would rather you call through, well, you know, they don't want you to call through low acuity stuff, but like in general, err on the side of caution. And I think this is the conclusion I came to pre-hospitally of like, if I'm not sure and I'm really wrangling, rather than just waiting and not making a decision, because, you know, the passive thing is not to pre-alert. Like if you don't make a decision, you don't pick up the phone and make a call. I came to the conclusion that I would always rather pre-alert and potentially look a little bit silly, because I think once you worry about looking flappy, you can get like too chill sometimes. And I think if you avoid making a pre-alert because you don't want to look silly, then you look really stupid when you turn up with someone that looks like garbage and you haven't called anyone and no one's had a chance to prepare. So I guess everyone gets to that in their own time, but I certainly found that out the hard way a few times. Then they would talk about lack of processes. So I guess we've talked about like the lack of guidance, or the lack of uniform guidance nationally. Like we've got this guidance document, but the trust don't keep to it. The ambulance trust don't keep to it necessarily. But also from an ED side, they've got their own processes. So like when you pick up the red phone, just miming that for you in case you don't know what a phone is. When you pick up the red phone, like who takes that call, what information are they asking for, and then how is that information distributed, like how's that information kind of cascaded down. There's quite a few places that can fall down. So where I work, both EDs where I work, one of which is a major trauma centre, there is like an A4 sheet and it's all really clear. It's like a space to fill in the obs, age, call sign, ETA, but like people don't always use that. There's a bit of free text space and sometimes there's just a scribble in there, and it's just like, actually if you're not filling out the form, it's really easy to like neglect to ask for certain bits of information. And I guess the ambulance side of that is if you're not giving like a nice structured APMIST handover for your trauma patients, then things will fall through the gaps. The one I always think of, I remember calling through an RTC. I can't really remember anything about it, but I called it through and I was like, you know, I've got a 50-year-old, car versus pedestrian, blah, 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 I'll be there in 8 minutes. And then I turned up and it was a major trauma call. It triggered something off, major trauma E. It triggered something off, so we went into the big room. All the adult bays, there's no one in them at all. And then I looked up and there was a peds bay with this major, like paediatric major trauma team, like ready to go, like all really fired up. I was like, is this for my patient? And they're like, yeah, 15-year-old. I was like, no, 50-year-old. So 15 and 50 sound really similar, and actually there wasn't really anything in place to stop that very easy misunderstanding happening. So after that, I always would be like, I've got an adult major trauma call, 50 years old, 50, maybe slightly overdoing it, but it actually, if you're not being like, I've got a pediatric major trauma call or an adult major trauma call, it's very easy to make those kind of mistakes. So, and it's like, those are the kind of things that need to be in processes. Like on that sheet, maybe there needs to be a like ticky box for adult or peds, because what a waste of resources. You know, I reflected on it, learned from it, but I feel like a pediatric anaesthetist probably has better things to be doing than like waiting for like an imaginary patient, because I've got I didn't have two numbers confused. The English language just makes two numbers sound really similar. What else did the ED guys have to say? Even 2 minutes is helpful. So I think there can be a perception that like if you're on top of it, just turn up, just rag around, and it is annoying, like because you've got loads of stuff to do when you're in the back by yourself, and you kind of think, well, like I'll just get there, but actually there's loads of stuff that can happen in that 2 minutes. So if you think about the juggling that's going on, that's not necessarily visible if you're from a pre-hospital perspective, but like if you've got a full resus or a full HTU, there's lots of juggling that happens. Who could step down? How can we make space? What's the safest way to get a bed for this patient? Like that's part of the senior decision making in the department, is always kind of, when it's busy anyway, it's always this kind of game of musical chairs. So you're letting that happen, and you're letting that happen without a poorly patient in front of them, which is particularly helpful. And it also allows for mental preparedness, which I think is a really big part of all of our jobs and any kind of emergency medicine work. It's allowing for that mental preparedness, that mental modelling, and then from a more practical perspective, it's letting you gather the team. It's letting you gather equipment. Like if you need loads of blood, like you don't want it to be in the fridge, you want it to be there to hand. And I think I've got a lot less experience in resus in ED than I do pre-hospitally, but I have found like doesn't happen very often, but occasionally a crew will just turn up at resus and either they haven't pre-alerted, or they thought someone else was going to pre-alert, or they did pre-alert and it wasn't passed on. Like those are kind of the ways that communication can fall down, and it's always a little bit messy, like when they just turn up and you haven't had a chance to think it through, you haven't had a chance to like ask a senior like, oh, if this happens, what if this happens, all that kind of mental preparedness stuff. You don't have your equipment ready, like everything's like you haven't quite got the bed ready, and it's always a bit of a mess. And I always think it's interesting because when that's happened, you're on such a back foot that I find for definitely the rest of that research shift, if not the next couple, every time the door goes, I'm like, in case it's someone else just being wheeled in, like just bleeding everywhere. So it does put ED stuff on the back foot, and actually, yeah, that 2 minutes is really valuable. So yeah, I guess these are the takeaways. Short notice is still useful. Read the 2020 guidance, it's there, and it's useful because clearly this is an area that hopefully there's going to be some improvement on. So it's worth seeing what RChem and the AACE think about it. Appreciate ED pressures and all the work that you don't see when you've made the pre-alert. And I guess also like one take or last takeaway is like, it's not just you. Like if you find this frustrating, like yeah, everyone does. I mean, I think we all know we do because people sit around and complain about it on the station and in the ED mess room. But yeah, it's a systemic problem. There's a lack of standardisation. It's not necessarily that you're doing it wrong. So it's nice having this overview of that. And I guess also nice that hopefully in 5-10 years time we'll look back and be like, yeah, wasn't it a little bit shambolic then? It was kind of all just vibes based and like 50% of pre-looks were pointless or not needed. Because yeah, it sounds like all of this is a really solid evidence base for bringing in some kind of national standards. We'll see. Also, I studied at the University of Sheffield and I work for YAS, so it's kind of nice to see them collaborating to make some useful research that I find interesting. So that is the pre-alert party done with. There's a few more little pre-hospital bits. One of which is, excuse me, pre-hospital ET intubation for traumatic out-of-hospital cardiac arrest and improved neuro outcomes. So this is Japanese research. And if you remember, actually, I've just pulled down the December issue because there was some Japanese research into out-of-hospital cardiac arrests in peds and looking at their like long-term neuro outcomes amongst survivors. I thought it was a little bit of a coincidence that there's more Japanese research. It's also about pre-hospital cardiac arrests. It's also about measuring neuro outcomes. So let me just double check whether it's the same people because I'm sure you're all on tenterhooks. Yasuda. Yeah, no. There is not one single researcher in common. So I guess Japan maybe just likes to consider neuro outcomes and like care about pre-hospital research. So that's great. It's not just one person. Yeah, so they looked at, this was a retrospective cohort study. So they're pulling the data rather than like out there with doing research, if that makes sense. So they pulled the data, they've got 1,524 patients, so 370 of those had a pre-hospital ET tube. They compared ET tubes with supraglottic airways, your LMAs and that kind of thing, and jaw thrusts. So the basis of this is there's conflicting literature around pre-hospital intubation. As paramedics will know, we used to do it, then they took it off us, and now Quick Care are doing it. The concerns there were largely around skill retention. It's potentially, if you're not in a quick care role, then it's like a halo intervention, isn't it? Like high acuity, low occurrence. So you could easily go 6 months without tubing someone, if not a year. So there was concerns of skill fade and like, and actually like, is there even an evidence base that it's more effective? So yeah, so this one talks, the baseline is conflicting literature. There's sparse evidence around neuro outcomes. So this is kind of like similar to that December piece about peds out of hospital cardiac arrest, of like there's not much data around the neuro status of survivors. So yeah, they compared them all, and the conclusion was pre-hospital intubations associated with favourable neuro outcomes amongst adult patients with out-of-hospital cardiac arrest who had severe chest injury or transportation time over 15 minutes. So I guess the takeaway from this, and I guess this is a quick care kind of a thing, but it's helping us, it's giving us a little bit of more nuance, isn't it? It's helping us identify optimal candidates for pre-hospital tubing. So rather than just like we're going to tube all the rest pre-hospitally, it's like actually they've got severe chest injury or prolonged hospital transport to hospital time, or both. We think they're going to be a really good candidate for this. They're likely to benefit. So I guess this is all just giving us a little bit more nuanced decision making potentially, rather than the protocol driven doing the same thing for everyone. And I think now the quick care role is established, then it's, if people are seeing more pre-hospital cardiac arrest, then they're going to be able to start making more nuanced decisions. So interesting, add to the evidence base. See what Japan gives us next month. Okay, and then we've got a quickie. So, excuse me. So there was a quick study done about basically in COVID. They noticed that some people's oxygen saturations were overestimated by SATS probes. So when they were doing ABGs, they were finding they had much lower oxygen levels than they had thought from SATS probes. So they've done a little bit of research, and basically if people have low hemoglobin, then it sends it off. So let me say it properly. As blood hemoglobin decreases, the SATS measurement, the SpO2 measurement derived from a pulse oximeter reads erroneously higher than the true value measured by an ABG. So this would be finger SATS probe is going to give you a misleadingly high reading if someone has got low hemoglobin. So I'm guessing the waveforms would be fine. That's what I'd always do. If I see a SATS that looks like not true on a monitor, pull up the waveform, and actually, like, if the waveform's good, I'd be pretty reassured. Anyway, don't trust the waveform. Turns out if you suspect they've got low hemoglobin, i.e. you know they're really anemic, they've got a history of anemia, or if there's any kind of hemorrhage going on, be really suspicious of that SATS, the peripheral SATS reading, and maybe have a lower threshold for oxygen. So that's a nice one to take away. Oh, and then there is one, where's the page? There is someone presented to ED looking blue. Annoyingly, devastatingly, you could say, it's printed in black and white. Just let me flip through all this pre-alert research. Here we go, man with greyish blue face. So yeah, it's in black and white sadly, but yeah, he turned up looking greyish blue. Turns out he'd been taking herbal supplements, which I'm presuming contains silver, because he is blue because of argyria, which is like a build-up of silver. And I have never seen this clinically, but I am aware of it because of extracurricular interest in weird cults and reading about them online at 2 a.m. when I can't sleep. Don't know if anyone else is aware of the Mother God cult. The cult leader, they were already into colloidal silver, and the cult leader was like taking silver supplements, and she turned totally blue, and then she died, and they wrapped her in fairy lights, and they mummified her body, and then anyway. So yeah, nice to see that in the EMJ, a Venn diagram of my interests of emergency medicine and weird cults. I don't think this person was a cult member. That information is not provided. And then final thing is there's a really nice piece at the end from an ED doctor and a midwife, and they're working on a Médecins Sans Frontières search and rescue ship in the Mediterranean, which is subscription only, but if you are subscribed or can get access through your institution, then well worth a read, and it's really nice to see some refugee solidarity work in the EMJ. So shout out to those guys and to the EMJ for publishing it. Okay, that's me done. 10 minutes shorter than usual, and I'm nearly done on the February issue as well. I'm trying to catch up after a busy winter. So thank you very much for watching. I'll see you next month, or realistically in a week or two. Thank you very much for watching. See you soon. Bye.